Hi, my name's Ian Battersby. I'm Head of Internal Medicine at Davies Veterinary Specialists, and welcome to another edition of our Davies Out of Hours podcast. As you know, we've adapted the setting a little bit. Normally we film these in like a tea room or the pub, but because of COVID, we're doing these remotely over Teams. We're doing a little series focusing on infectious disease, and we've covered Leishmania, Leptospirosis, Babesia and Ehrlichia so far, and they're all available to download. And today I'm joined again by Patricia, as we're going to talk about Diarrhea. So hello, Patricia.
Hello, Ian. Hello, everybody.
Hello.
Nice to see you again.
Nice to see you again. How's your last 24 hours of lockdown been? Been doing any remote consults or?
I did some yesterday,
yeah,
which were good. They were my first remote consults that I've done since lockdown.
Yeah, so it's a big thing for us to adapt to, really, isn't it?
Yeah, and actually I enjoyed them. It was nice. I thought it was going to be a little bit weird, but I enjoyed them.
Cool. And my day wasn't quite as exciting. And well, you'll say it was exciting for me. You'll say it's boring, but we've lived in our village for 14 years, and we found a new route to walk on. Which is groundbreaking for the kids. Behind supermarket, through some bins. Not the most beautiful, but exciting for us. That's how life is at the moment. But
very good. We entertain ourselves with simple things these days.
Absolutely. So we're going to talk about Diarrhea.
Yes.
A nice place to start, I guess, would be talking about the distribution of Diarrhea, where we find it. Where we, particularly if we've seen a travel dog, what countries should we consider it in?
Well, it's all over the world, and there are incidence maps. There is a very good website, which is the Canine Vector-Borne Disease website, where they've got maps, and you can see in which areas of the world certain disease is, and you will find that Diarrhea is all over the world. With us, we're particularly with the dogs that we see are normally dogs that have been imported from European countries, and with regards to Europe, it's in kind of southern European countries, so along the Mediterranean coast mainly. You also see it's quite prevalent in the US, in many states in the US. But as I say, if in doubt, just check one of these maps in the Canine Vector-Borne Disease website. And yes, and also just to mention that it is moving north, the disease. So it's expanding to areas where it wasn't before, due to different circumstances. And certainly we can discuss that if you want.
Yeah. So, well, and I guess an important aspect of understanding why this parasite is moving farther north and changes is understanding the life cycle, and how it's transmitted, because ultimately an environment has to support that life cycle. And I know that, as you know, I always get this bit wrong. so it's not sandfly. That's not this disease. It's the mosquito. I don't know why.
The mosquito.
It is the mosquito that's important.
Multiple different species of mosquito can transmit Diarrhea.
Okay. And naturally, mosquitoes survive in different environments. So you could even mention the global warming, kind of weather systems changes and things like that are going to, we've mentioned with Ehrlichia how some of the ticks can live in central heated houses. But with mosquito, that's going to be more of a general environment aspect, I presume.
Yes, we have the mosquito in this country. So the mosquito is present here, and that's one of the big challenges, because we've got the vector, and like some of the other diseases that we've discussed, for example, Leishmania, we do not have the vector in this country. We do have the mosquito in this country.
Okay.
But the organism, the larvae, it needs to, within the mosquito, it needs to molt from Microfilaria to L3, and that requires certain temperatures sustained over a period of time that we don't tend to get in this country for that sustained period of time. But with global warming, that may change.
And is that weeks or months or?
It is weeks. So the higher the temperature, the quicker the organism develops. But it needs temperatures over 14 degrees for 2 to 3 weeks. At temperatures of 24 degrees, for example, and I mean sustained temperatures day and night over 24 degrees, it can develop from L1 to L3 relatively quickly. As the temperature goes down, the development is much slower. If temperatures drop below 14 degrees, that halts the development of the organism.
Okay, so it's not like a really hot couple of weeks in the middle of summer is going to do it. It needs to be a sustained period, like you say. Okay.
Day and night.
Day and night. Yeah. Okay. So we've talked about, I suppose what we should talk about is how these patients are clinically affected by diarrhea. What presentations may we, what are the clinical signs that might raise suspicion that we need to screen for it?
So quite often, and they can have a range of clinical signs. So some animals will be infected and have no clinical signs. Some others will have relatively mild clinical signs. So maybe just a cough, maybe a little bit of exercise intolerance. Other dogs will develop very severe clinical signs, which could range from very severe persistent cough to right-sided congestive heart failure, to even cavil syndrome, where there is obstruction of blood flow and the animal collapses, weakness, even hemolysis and hemoglobinuria. So there's a wide range of clinical signs.
Wide range of severities, and cavil syndrome's life-threatening. Emergency therapy.
I mean, without treatment, those animals will die within a couple of days.
And if you're suspicious of, I suppose that's the thing we have to bear in mind, is that not all heartworm cases are going to present in cavil syndrome. So there's going to be an array of presentations, and if you feel that the presentation and the clinical history, the travel, and things like that is warranting screening, and testing, how would you go about that?
So I suggest that animals from endemic areas should be screened on arrival in the UK. The screening tests, there are really two tests for the Microfilaria. One is the antigen tests, which are qualitative tests, so you get positive or a negative. And they're looking for antigen, they run on blood, and it's the antigen of the female organism. So you need to have at least one adult female in that particular dog for it to test positive. So you can imagine that you can get false negative results if you've got, for example, a small number of worms and they all happen to be males, or if you've got immature parasites. So L3, L4 or immature adults may give you false negative results. So if you test too early, after infection, so for example, if an animal has come in and was infected 2 months ago, you will get a false negative result.
So with that in mind, if you have a dog that's been abroad and it's been to an endemic country, or it's rescued from an endemic country, and you're going to screen it and you get negative testing, would it, again, I'm just asking the question, would there be merit in saying, okay, I've got a negative now, there's a, and have that discussion with the owner that there may be benefits of repeating the test in 2 or 3 months?
Definitely. So I'd say repeating the test in 6 to 9 months, because it can take 6 to 9 months for them to become adults. It's one of the kind of slowest worms in development. So it does take time. Minimum 6 months, but it can be up to 9 months for them to develop into adults and give you positive results on antigen testing. And that's why nobody will test a dog younger than 7 months, because the likelihood is that you'll get a negative result. So, you have to bear in mind the life cycle of the parasite.
And that comes down to something that we've said throughout all of the infectious disease podcasts. You've got the tests, but it's understanding when those tests perform best and how you use them, and you can only do that by having a good understanding of the life cycle of the disease, really. And how it clinically presents. So, okay. So we mentioned the antigen test. Did we mention the other test?
Yeah. So the other test is the Microfilaria test. So when adults reproduce, they produce microfilaria, which are the infective stages of the parasite. So those are the ones that the mosquito will take when feeding from the dog, and then develop them into L3 and then pass them on to another dog. So once they have adults, if they've got a male and a female, they will produce microfilaria. So if you see microfilaria, which are kind of the very early stages of the larvae, then again, that would be consistent with infection. Just bear in mind that not all dogs infected with Drofilaria will be microfilariamic. So if you get a negative result of a microfilaria test, that does not mean that the animal is not infected.
Yeah. So then
obviously, if you see them, then you know that the animal is infected.
Okay. And then of course there are some cases where I suppose a cardiologist would comment more, where they have a patient that is referred, presents with signs of right-sided failure, and then they'll either sometimes see the worms, I guess.
Yes. So you can see them on echo, and that's another way of diagnosing the disease.
Or alternatively, they find those cardiac changes and then decide to screen for it.
Yes. Yes.
So not quite based on clinical presentation, more on their other diagnostics. Okay.
Yes.
So if we diagnose a case of Drofilaria, you've already said that there's a range of clinical presentations. So I presume, depending on the severity of disease at what stage, depends on the treatment option, really.
Yes. So if you have a very severely affected dog with lots of worms, so heavily infested with, for example, caval syndrome, then in those cases, our preference would be to surgically remove the parasite. I say surgically, but it doesn't involve opening up the animal. It's just, you can do it by fluoroscopic guidance using a catheter introduced through the jugular vein and into the atrium and the pulmonary artery. So that's one way of removing the worms.
So that's in the most serious cases where you've got a heavy word burden, potentially have carval syndrome or have quite significant cardiac dysfunction.
Yes, and you want to get rid of the worms as quickly as possible.
You want to get rid of the worms quite quickly. Is there a potential problem as well of killing such a high worm burden, if you use medical therapy in those cases?
Yes, so a medical treatment in these cases is very risky. It's slow killing process as well. So, it just depends on the time that you have to do that. And doing it medically would be appropriate in a dog with minimal clinical signs.
Yeah.
But in a dog with severe clinical signs, you would be better off taking the worms out. There is a big risk of anaphylactic reactions when the worms die.
Yeah.
And also thromboembolic disease. So death as a result of worm death is not uncommon, particularly in dogs with severe clinical signs.
Okay.
So there's a big risk with treatment.
So it's a big risk with treatment, hence the more invasive route to remove them.
Yes.
But if you are using medical therapy, have we mentioned the drug? I can't remember. I don't think we've mentioned the drug.
No.
So if we're using medical therapy, do we use, you've mentioned the thromboembolic risk and the anaphylaxis. Do we use, for example, steroids to help with the anaphylaxis? And what about, antiplatelet, anticoagulant therapy?
Yeah. So there is a very established protocol for these cases. And I would advise that you go to the website, which is the American Heartworm Society website. It has got a lot of information on the parasite itself, diagnosis, treatment, and the protocol is there, the protocol for the American Heartworm Society. And it's a protocol that most people use because it's thought to be the most effective and the safest protocol that there is. And basically what they do is they start steroid treatment to reduce the risk of anaphylactic reactions, inflammatory responses, and so on. And they also insist on strict cage rest while the animal is under treatment, because the animal remaining active significantly increases the risk of thromboembolic disease.
Yeah.
So we advise that they are cage rested throughout the treatment, which is tough because it goes on for weeks, months. Now, they start with steroid treatment, and also they give the Heartworm Preventative, which is either milbemycin, moxidectin, or selamectin. The reason is that you will get you with those treatments, you will start off killing the early stages of the parasite, so L3 and L4. You will also kill some of the microfilaria as well. So what you're trying to do is you're not yet tackling the adults, you're just tackling the immature stages. Now, you can get some anaphylactic reactions when you're doing that, but not as severe as you do with the adult worm. But you're just trying to get rid of the immature stages at this point in time. They also start treatment with doxycycline at this moment in time. And they do that for 4 weeks. And the reason is that they are trying to get rid of Wolbachia. Have you heard about Wolbachia?
No. It's a learning day.
It's a kind of symbiotic organism with Drosophila. So it's a bacterial organism, and it's thought to play a really important role in the pathogenesis of Drosophila. So some of the anaphylactic reactions associated with the death of the worm could be related to Wolbachia organisms. And it's been shown that if you get rid of Wolbachia before the death of the parasite, you significantly reduced inflammation within the kidneys and the lungs and so on. So you want to get rid of those organisms early on.
And the Wolbachia, is that's not just in one particular country? It's not like you only see it with Drosophila, it's worldwide?
Yes, it is. Yes.
Okay.
So the protocol involves starting off with that doxycycline treatment to get rid of that organism. So you do that for the first month, and then the second month, you repeat your Heartworm Preventative. So you give your either milbemycin, selamectin, or moxidectin again. And you carry on with your cage rest. And you're just doing this kind of slow worm death, if you like, with getting rid of those initial early stages of the larvae, and hopefully getting rid of your Wolbachia that you've already done the first month. And then it's in day 60 that you would give your first heartworm treatment.
Wow, so it's a very staged, slow process, isn't it?
Yes, so that's your melarsomin. And then you would do 3 treatments of that. One on day 60, one on day 90, and then one on day 91. So 3 treatments in the space of 2 months. And it's a bit confusing talking about it like this. I think it's better to see it in a chart. So go to that website and have a look at the protocol, because it's quite self-explanatory.
And yeah, I suppose that's a little bit like the leishmania. You know, you've got different grades of diseases that you do, different timings of treatment based on renal function and things like that. Okay. Now, what we probably should mention is we'll tag on the end of this video version of this podcast a little video of a patient having worms removed via the jugular vein. So, you know, you can either fast forward, have a look if that's what you want to see, or hold on at the end of the podcast so that you'll be able to see that and see real time the kind of huge burdens that these patients have. So finally, I suppose we've got our patient, and we've either medically managed it, as you say, in a very controlled patient way. I presume that when you, if we come back to the dogs that need, removal of the worms, I presume, do they then go onto the medical management regime?
Yes, because you won't have got rid of all of them. It's unlikely that you will have removed. Some of them will be in places that are not accessible. So you're just trying to remove the bulk of them. But then you will be left with some adult worms, and of course you will be left with microfilaria, and of course you will be left with immature stages of the worms. So you will be left with L3, L4. So you need to get rid of all of that. So they would still go on the protocol that we described.
Okay. So how then do you monitor these patients? Again, I suppose that varies a little bit depending on the severity of disease. So if they've got severe cardiac changes, they're going to need echoes, I presume.
Yes.
But then there's other aspects of monitoring as well.
Yes, so you want to repeat antigen testing and microfilaria testing, but they can take months after the end of treatment before you will get a negative antigen test. So you want to wait at least if you're getting, so you can do the test, say you do your antigen test and you do your microfilaria test, say 7 months after starting treatment, and hopefully you'll get a negative result, but you may still get positive results up until 9 months or so after starting treatment. So it's worth waiting a bit before considering restarting treatment, because it can take a little bit of time. Remember, it's an antigen test. So the antigen may well be floating around for some time, even if the worms are actually dead.
Okay.
So it can take a bit of time to be sure that you've got rid of the organism.
Okay. And I suppose we should talk about how these patients do, because it's quite a involved treatment, even if they're mildly effective. Do you clear is it a good prognosis to clear it? I presume the more severely effective depends on the degree of cardiac changes they've got. Are they reversible?
So yeah, I mean, it's a real devastating disease, because obviously you can clear the parasite. You know, we have very good drugs that get rid of the organism, but it does leave behind some very chronic changes, both in the lungs and in the heart, that are quite often irreversible. So what I'd say about heartworm is that for the animal that gets it, the treatment is difficult, long, and they can be left with some chronic changes. But it is a very preventable disease. So we have very good preventative treatments that are very effective if they're used on a monthly basis. Just missing out on one single dose can be the difference between an infected dog and a not infected dog. So I would say to people, if you do travel abroad with your dog, just make sure that you follow instructions on preventative treatment, that you don't miss any doses, that you do the treatment sometimes. It is a very preventable disease, and you definitely don't want your dog infected.
So the preventative, that's medication, but also there's other things that you can do to help reduce the life cycle, I guess.
So these macrocyclic lactones that we've been talking about, so milbemycin, moxidectin, and selamectin, we talk of them as preventative, but they're not preventative in the sense, they're not like a vaccination. The animal will get infected, but you will kill off the early stages, so you will kill off the L3 and the L4. They're like worming treatments, in effect. But you kill the parasite in the very early stages before it causes any pulmonary or cardiac disease. So that's what you do with those preventative treatments. There is obviously the other preventative treatment, which is do not take your dog abroad, well,
and then minimize the risk.
And then it doesn't come in contact with the infected mosquito. If you absolutely are going to take your dog to endemic areas, then use mosquito repellents. And we do have some good drugs out there that act as repellents for mosquitoes, so that your dog doesn't get bitten in the first place. Just bear in mind that with any repellent, they're not 100% effective. So you still want to use your microcyclic lactones. You still want to use your milbemycin, your moxidectin, and your selamectin, even if you are using an insect repellent. And also avoid taking your dog out at times when the mosquito is active. So that's usually very early in the morning or very late when it's starting to get dark. That's when the mosquito becomes active. A bit like the sandfly.
Double management. But I guess the insect repellents, the mosquito repellents, I presume that are they veterinary products for dogs?
They are veterinary products. I guess I'm not allowed to mention.
Oh no, don't mention trade names. But
they're out there, and they are repellent.
But it's not a matter of going down to your local pharmacy and getting some for yourself, and then thinking that will cover your dog as well.
Oh, no, definitely don't do that, because some of those products are poisonous to dogs. So you always use a veterinary licensed product, of which there are a few.
And I suppose we've mentioned dogs all the way through this. What about cats?
Well, cats do get Neurofilaria. They're probably, they get infected. They appear to be maybe less susceptible for whatever reason. And maybe they're better at dealing with the infection themselves, I don't know, but they seem to have Less worm burden when they do get infected. So it's not uncommon for cats just to have 1 or 2 adult worms instead of, dozens of them like dogs do, or sometimes hundreds of them. And they get aberrant locations sometimes, so they can get the infestations in the heart and just kind of weird, in the brain and just kind of weird places like that. So yeah, they're interesting in that sense, but they can become infected, yes. And they're very difficult to treat when they become infected because melasmine is toxic to cats. So in cats, you have to remove them physically because there's no other way of dealing with the problem.
Wow. Okay, if they're accessible.
Yes.
And then presuming if they've got a lower worm burden, do they present with less severe clinical signs?
Yes, they can have less severe clinical signs. Sometimes no clinical signs. Sometimes they can cough, look a bit like a cat with asthma. Or they might have very vague symptoms like vomiting, diarrhea, just being a bit off color. I said that removing them may be the only way to deal with them, but in cats, sometimes people just leave them infected and just wait for the worms to die because they have relatively low relatively low numbers of worms. They sometimes just wait for the worm.
So I suppose it's just weighing up the risk because they're unlikely to get a high worm burden that's going to affect them very severely, like a dog.
Yes.
The risk of treating them, causing anaphylaxis, or trying to remove something that may be difficult to do, it's better to just live with it.
Yeah.
Okay. That's interesting.
And just get put them on heartworm preventatives to just kill off the larvae so that you don't get new adults as they develop.
Okay, cool. Well, thank you as always, Patricia. Really informative. I hope that's useful for everybody who's listening. Just a quick reminder that we have got a series of other Out of Hours podcasts not related to infectious diseases, namely cardiology ones, surgical ones. They can all be downloaded. We'll leave an email address so that you can contact our marketing department. They can forward them on to you. I think the next one we're going to do is on mycobacteria, but that's with Catherine rather than yourself, Patricia.
Yes, that's right.
So thank you once again, and to everybody who's listening, stay safe.
Thank you very much, and I'll see you soon.
See you soon.
Take care. Bye-bye.
I'm videoing. Oh my god. Oh my god, the lens. Wow.
See how long they are?
Yeah. That is amazing. Oh my god. That is absolutely amazing. Oh my god. Well done, Pedro.
Moving.
Oh my god, it's still alive. They look like
Okay, Julie, make sure we don't